Hi, everyone. My name is Stephanie Suarez Gonzalez. I am the Clinic Partnership Manager here at MAVEN Project. Thank you all for joining us today and for our friends at El Dorado Community Health Center for hosting today's session, Interpreting Abnormal Endocrine Tests, When to Worry and When to Reassure by Dr. Paul Kaplowitz. Dr. Paul Kaplowitz is a professor of pediatrics at George Washington University School of Medicine and the Health Sciences, and in the Division of Endocrinology at Children's National Hospital in Washington, D.C. His areas of expertise include short satire and thyroid disorders, and he is especially well known for his work on precocious puberty.
Precocious.
Thank you. Since retiring from Children's Hospital in 2018, he has been volunteering at Neighborhood Health VA, a federally qualified community health center in Alexandria, Virginia. In addition to in-person care, he often consults by email and through the EHR with members of this multi-site practice on abnormal tests and worrisome growth charts. And with that, I will pass the floor off.
Hello, everybody. I understand that my audience has many family practitioners. I'm a pediatrician, and so these cases are those seen in pediatric endocrine practice, but many of them are also seen in adults. Oh, I'm having a hard time. Okay, that's true. Okay, so I don't have any financial relationships to disclose. I am not advocating for any drugs or tests. And this project is accredited for one Category 1 CME credit. So our goals are to discuss several cases involving somewhat abnormal endocrine studies to illustrate how an endocrinologist would interpret and act on the results. Also, we want to get into the more general issue of trying to define when a test is truly abnormal and if it relates to the problem which led to ordering the test in the first place. And my ultimate goal is to encourage thinking about doing less endocrine testing in situations where truly helpful abnormal test result is unlikely. So when I present these cases, unfortunately, Stephanie, I cannot see the chat box in my on my screen. I don't know.
Yeah, no worries. I gotcha.
So I'm going to present some cases, and I'm going to encourage you to put in the chat, which option you would choose, and then Stephanie will, after, maybe a 30-second delay, she'll tell me what option was the most selected one. So, first case is a 13-year-old girl brought in because of severe fatigue for the last 3 months. She's getting plenty of sleep, but has trouble getting up in the morning, no change in her appetite. Medical history is negative, physical exam is normal. So you order some tests, and you get a CBC, a comprehensive a metabolic panel, titers for EB virus, but then you get the thyroid, and her free T4 is normal, but the TSH is elevated. So my question is, what would you do next? Repeat the tests, consult with a pediatric endocrinologist, start thyroid hormone, and then try to get her seen by an endocrinologist as soon as possible, or tell the parents that none of the tests ordered suggests a particular reason for their daughter's fatigue. So why don't you think about this and then put in the chat box which option one to this particular case. Do we have any answers, Stephanie?
They're starting to trickle in. So I have 2 people that said 3, and then a few other people are saying 1 and 4.
Okay. All right. Well, that's a good. By the way, I can now see my chat thing. So, okay. So I'm gonna do another case. before we discuss the first case. So this is a 10-year-old boy who's obese and he's 40 pounds above his ideal weight. He has thyroid tests to exclude hypothyroidism. The free T4 is a little low and the TSH is normal. So and these are A, B, C, and D. Would you refer to endocrine for suspicion of primary hypothyroidism with delayed TSH rise? Would you be more concerned about a pituitary problem? Would you view the results as benign normal variants or repeat the tests? And if the results are the same, get them seen, have them seen quickly by an endocrinologist. So why don't you let me know if people are choosing A, B, C, or D?
Okay, they're still trickling in. Give it a few, 20 more seconds. Yeah. Looks like we're choosing D across the board.
Okay. All right. So let's discuss. We're going to review a bit of thyroid physiology. So when everything is working properly, an illness of the thyroid, which results in usually a low T3, T4, and or T3, will result in a loss of this negative feedback. And then you will, because of the loss of the negative feedback, you will get a significant rise in TSH to restore normal levels. So in theory, an elevated TSH should mean something's wrong with the thyroid. But in these cases, I think we need to think about a couple of things. And first of all, we have to ask yourself if the out of range results are meaningful in the context of the patient's symptoms. Are they abnormal enough to explain either the severe fatigue or the 40-pound excess weight? So patients with true primary hypothyroidism, even mild cases, will typically have a TSH of greater than 10. And those patients are still borderline, but those with a TSH of greater than 20 are really those that should be seen promptly. But the symptoms are very variable, but they really depend on not on the TSH, which causes no symptoms, but how low the free T4 is, because that's measuring active thyroid hormone in the blood. And it also depends on how long it's been going on. Now, secondary hypothyroidism will result in a low free T4 and a normal TSH, but this is really quite rare without other pituitary problems or a history of a brain tumor or brain irradiation. So, in my advice is to not worry about, the normal free T4 and TSH of, 5 to 10. And also don't worry about the borderline low free T4, which is almost always a normal variation. If the free T4 is significantly low, like less than 0.7, remember the normal range is 0.9 to 1.6, one option you have before you send to your local pediatric endocrinologist is to consult with one of the MAVEN endocrine or pediatric endocrine specialists. Okay, so now you're seeing a 15-year-old girl who complains of losing 10 pounds in the past 2 months without trying, despite an increased appetite. She also feels warm when other people in the same room do not. Her past medical history is unremarkable. What would you look for on physical exam that might support a diagnosis that you're thinking about? Well, I'm going to go ahead and give you the things that you should be looking for. First of all, look for a large symmetric goiter, which she has. Heart rate is elevated, and the pulse pressure, the difference between the systolic and diastolic, is rather wide. She has brisk pulses and increased precordial impulse. Her skin is warm and moist, and she's kind of fidgety. She has trouble sitting still. So my next question for you to put in the chat is, what tests would you order that are, I'm talking about the tests that you really need to make the diagnosis, as opposed to the tests that a specialist seeing this patient might order for completeness. Do you have any answers yet?
I have one answer. It says TSHFT4. Somebody else is saying T4, TSH.
Okay. All you really need to confirm your suspected diagnosis is a total or free T4 and a TSH. And, in true hyperthyroid cases, that this one seems to be with all the symptoms and the goiter, they will not be borderline. The free T4, which has an upper range of normal of 1.6, is almost always greater than 3, and the TSH will be suppressed, not just low, but unmeasurably low. But there are a lot of other tests you could order: T3, various thyroid antibodies, and imaging such as a thyroid scan. That can be left to the discretion of the endocrinologist. What you want to do is confirm the diagnosis so you can not just say, call, the so-and-so clinic and see when they have another appointment, which could be 2 or 3 months away. But this is one where getting on the telephone and talking to and the doctor on call should be able to get your patient um, in a few days. So when do you really need to do thyroid testing? And first of all, keep it simple. For screening, a total or free T4 and a TSH is sufficient. You don't need T3 because that's almost always just going to confirm what the T4 shows, and you don't need the antibodies, at least for screening. And obviously, you want to order a thyroid test if you have a goiter, especially if it's not been there for that long. You want to order thyroid tests when you're following up on abnormal newborn screening results. In a rare situation, but an important one, is if there's been a significant fall off in growth in the last year. And I'm not talking about a patient who's, late pubertal and has, reached their adult height, but in a younger child, a significant fall off in the past year. It's a good reason to do thyroid. And then signs and symptoms consistent with hyperthyroidism. Hypothyroidism can be asymptomatic, but if there's new onset fatigue, not like they're always tired, but recent onset fatigue and colon intolerance. But the situations where thyroid tests are of low yield are screening for obesity is very low yield. Most changes in behavior, a family history of thyroid disease, or irregular periods. Those are not the best reasons for ordering thyroid tests. Which leads us to the question of whether any endocrine labs should be ordered as part of an obesity workup. So hypothyroidism and other endocrine disorders, for example, Cushing's disease, are really very rare causes of obesity, well under 1%. And even in hypothyroidism, the weight gain in hypothyroidism is moderate. It's not 40 pounds. It's, 5 to 15 pounds at most. And it's due to fluid retention. So you often see a puffy edematous face, and it's not excess fat. But if rapid weight gain is accompanied by a slowing of linear growth, assuming the patient's not late pubertal, then the chances of an endocrine issue are much higher, and referral to an endocrinologist is more appropriate. But the crux of the problem is that we often see patients who present with nonspecific complaints, such as fatigue, or common problems such as obesity, that do not point to a specific medical explanation. So in hopes of finding something, a lot of tests may be ordered to make sure, quote, to make sure we aren't missing anything. And in some practitioners order metabolic panels and CBCs for screening purposes unrelated to any complaint. And when one, excuse me, and when one of these tests is mildly abnormal, should we assume that the abnormal test is clinically significant? The problem is that the boundary between normal and abnormal is much fuzzier than many of us are aware, because the definition of normal in most labs is the 95% confidence limit. So here's your, bell curve of a lab test, and 95% is this in between this line. But you can see that on each end, there's, about 2.5% of patients who are normal who fall outside this 95%. So how do we know if this person whose test is just outside the normal limits has a normal variant or real disease? And that's a problem because a lot of times, these borderline abnormal tests are just normal variations. So let's talk about a scenario that you might see is a 5-year-old overweight Hispanic boy is sent to you for some screening labs. 3 days later, you receive a report that his CBC and urinalysis are fine, but on his metabolic profile, his glucose is 118. And the parents tell you that he always drinks a lot. So what would you do? Order an A1C, refer to pediatric endocrine for a type 2 diabetes evaluation. Repeat the glucose, but make sure the child is fasting because this was done at 10 a.m. Or order a 2-hour OGTT with insulin levels. Okay, I will wait for some answers to show up.
Little bit of a mixed bag, but for the most part, I'm getting A. I do have some B, C, and D though.
Oh, good. Okay, well, what would an endocrinologist do? First of all, while type 2 diabetes is becoming much more common in obese children who are over 12, it is extraordinarily rare for it to present in a child as young as age 5. So a random blood sugar of 118 is most likely normal if the child had consumed a lot of carbs 1 to 2 hours earlier, and you were not reassured that this was a fasting glucose, so and it was 10 a.m., so you have to consider that. Um, since the renal threshold for glucose is about 180, you would not expect polyuria or polydipsia. And these parents did not report new onset polydipsia. So the conclusion would be that this is unlikely to represent either diabetes type 1 or type 2, but to be, sure, the best follow-up test would just be a fasting blood glucose. Okay, but then that asks the question, brings up the question of when should you order a hemoglobin A1C in kids to rule out either diabetes or prediabetes? Um, this is a challenging question, and there's really no right answer. Yearly screening in severely overweight kids, such as with a BMI of over 30 or 35, over the age of 10 and 12 or to 12 has been recommended, particularly if there are other risk factors such as ethnicity, race, and family history. But it's very rare that you will actually identify a type 2 diabetes with a hemoglobin A1C of 6.5 or higher. Much more often, the test will be in the borderline range that you've seen on so many lab reports, which is consistent with prediabetes. Now, prediabetes may progress to type 2 diabetes over time, especially if the weight gain continues. But this could take months, it could take years. So it's really tough to decide whether intervention is necessary. Now, as was mentioned in the introduction, I do volunteer in a FQHC, and I am referred many obese kids with that prediabetes range hemoglobin A1C. And I, will often treat with metformin, which is off-label because it's only approved for type 2, if the hemoglobin A1C is above 6%. And that, will probably delay progression to full-blown diabetes, but, it's not going to cure them. So the question is, will identifying a child with prediabetes by doing an A1C motivate the child and the family to make needed lifestyle changes? That would be the most optimistic reason for screening. And the answer is maybe. Some families clearly do get motivated, and other families keep, with the unhealthy diet and poor exercise patterns. So here's another glucose scenario. This is a 5-year-old boy who had a screening urinalysis with 2+ glucose, and you send a basic metabolic panel, and the glucose, which was not fasting, is 225. The parents deny he's healthy, and they deny any history of polyuria or polydipsia. So how would you proceed? Have parents remove high sugar drinks from the diet, discuss with a pediatric endocrinologist, do an OGTT with a hemoglobin A1C, or have the blood sugar repeated if and when symptoms of diabetes develop. So let me give you 30 seconds to put your answers in the chat.
Okay, looks like the most common answer is C. We also have some A and B.
Okay. Well, what would I recommend? First of all, a random blood sugar of over 200 is diagnostic of diabetes, even in the absence of symptoms. Whereas a random blood sugar in the 150 to 200 range is suggestive but not definitive. Unless, of course, the child is on medications like high-dose steroids, which can elevate blood sugars transiently. And at age 5, this is most likely early type 1. So the problem is that during the time it will take you to schedule and review the results of an OGTT, your patient could become, much sicker and conceivably even go into DKA, although a few days is usually not too more rapid than is typical. But this is a case where having a pediatric endocrinologist involved early will make sure that the definitive testing, fasting blood sugar, OGTT, A1C, in this case, probably an A1C would be adequate to confirm the diagnosis. But you definitely want to be in touch with the pediatric endocrinologist, because this patient's going to probably need to be seen fairly quickly. Okay, another case. This is a case that is probably very familiar to the pediatricians in the office, of a 7-year-old girl who's found on her well child check to have pubic hair and underarm odor for the past 6 months. Her height is 90th percentile, weight is 95th percentile, there is no breast development. The genital exam is normal except for pubic hair. The parents do not seem particularly worried. What would you do? So the first is to order the typical tests, that are elevated in precocious puberty. The second is to order tests that more looking at adrenal and test hormones. Or you could reassure the parents without testing, or you could send to the pediatric endocrinologist and let them decide what to order.
I'm giving it a few more seconds. All right. Okay. The most common answer is a 1, but I also have 2 and 4.
Okay. Nobody picked 3, huh? Okay, so let's say you decide on option 2. And what you find is that the DHEA sulfate is increased for age. The 17-hydroxyprogesterone is normal. And the testosterone is okay. By the way, I didn't include the LH, FSH, and estradiol because those are tests that are helpful if you are looking at either breast development, breast development. They're not particularly helpful when there's no breast development and you're looking at mainly signs of androgen exposure. So the question is, would your next move to be tell the parents that your tests are about what you expected, but if they wish, they can see a specialist to be sure. Would you order a CT scan of the adrenals or try to get this patient in quickly because the elevated DHEAS makes you worry about an adrenal tumor? Any responses?
Yeah, I'm getting a mixed bag again. Lots of 1s, 2. I have a 3 and a 4, but mostly
I
1.
didn't even have an option 4.
Oh, I'm gonna put 4.
All right. Well, those of you who see kids are hopefully aware that the case that I described is a classic case of premature adrenarche, also known as premature pubarche, which is a benign normal variation of puberty. And it's due to, an earlier than normal increase in adrenal hormones, androgen secretion. And typically, the only abnormal finding is a modest increase in DHEA sulfate. As I mentioned, LHF, FSH, and estradiol are not helpful in this context. In virilizing tumors or congenital adrenal hyperplasia is extremely rare, and you would see in girls an enlarged clitoris. So the important thing about this case really to is to recognize that this is a benign normal variation. And, many times parents, either the doctor, the provider, or the parents want some reassurance. And so I think it's fine to refer these patients to an endocrinologist if they need reassurance. But my argument is not to order labs ahead of time. The reason is that um, diagnosis can be made clinically, and the labs are expensive, and if the endocrinologist happens to be one that orders these tests all the time, fine, but you do not need to order these tests. Leave it up to the specialist or reassure the parents. Okay, so we're going to move into the area of vitamin D. You're seeing an overweight 10-year-old and you decide to screen him for vitamin D deficiency. The vitamin D level comes back 20.5 with the lab normal range being 30 to 50. On his CMP, his calcium and alkaline phosphatase are normal. Would you prescribe 50,000 units of vitamin D weekly for 8 weeks, as some articles recommend? Would you assess his vitamin D intake? Is he drinking any milk? Is he taking a multivitamin? And if it's low, you could suggest a daily vitamin D supplement. Or you could consider that his vitamin D level of 20.5 is fine and do nothing. So we'll call those options 1, 2, and 3.
Okay, looks like we got some more unanimous for 2. Everyone said 2.
Oh, okay. All right, well, let's see. This is a complicated issue because while the Endocrine Society and other groups have in the past recommended that vitamin D levels should be greater than 30, most experts nowadays feel that any level of greater than 20 is adequate and that evidence of vitamin D deficiency is rare unless vitamin D levels are quite low, as in less than 12. So in this situation, you can certainly, there's no harm in giving a vitamin D supplement. But I mean, the question is really, how important is it to screen patients for vitamin D deficiency? And the truth is that measuring vitamin D should mainly be done when you get a serum calcium that's very low, but especially if it's less than 8, and especially if you're dealing with a breastfed dark-skinned infant or evidence of rickets on X-ray or exam. You can see bowing of the lower extremities. You can see widening of the wrists. But the truth is that those situations are relatively rare. I've certainly seen my share of vitamin D deficient infants, and it really is almost always breastfed, dark-skinned infants who are not being vitamin D supplemented. Now, in other situations, including obese children, there's really, the Endocrine Society does not make a case for universal screening for vitamin D. It is true that overweight children have somewhat lower vitamin D levels, but it's really best to assess milk intake and sun exposure and advise a daily supplement. For most kids, 600 units is adequate, but 1,000 units is very safe if vitamin D intake or sun exposure appears to be low. For obese children, they tend to require somewhat more, so 2,000 units a day may be needed. And I know a lot of people aren't comfortable with this, but the truth is it's far more effective to do widespread, cost effective to do, make sure that everybody is either getting adequate dietary D in the form of dairy products or taking a supplement than to check a vitamin D level, find that it's a little low, supplement, retest, and keep on retesting. And these tests are add costs, but really don't have much benefit. So let's talk about test ordering and the cost of healthcare in general. Ordering more tests than is necessary contributes to the rapid rise in healthcare costs without making children any healthier. It's particularly true of tests ordered for completeness when the H&P do not point to a specific diagnosis. One abnormal result often leads to retesting, so that increases expenses. So one example that I use for unnecessary healthcare testing is the short, healthy short child who is growing normally close to the fifth percentile. And I can tell you from experience that this scenario often results in ordering a large panel of tests that look at, all possible causes of short stature that a blood test might reveal. But there was a study published in 2013 from Cincinnati, which looked at the value of typically ordered screening tests in over 300 children with a normal exam and a normal rate of growth. And there was only one patient in those 300 who was really very short, was found to have a lab test that was clearly related to his short stature. And that was a very high tissue transglutaminase IgA, which led to a diagnosis of celiac disease. And this is what these tests cost at Children's Hospital. Now, um, this is what our charge master shows, and I'm sure this is not what insurance company pays, but if you don't have insurance, you're going to be billed for, all of this. And it's really amazing how much it adds up to the CBC, the CMP, the SED rate, the thyroid test. One thing notable about thyroid tests is that a free T4 is, well, more reliable and less affected by thyroid binding proteins, is less is costs about $100 more than a total T4. If you're monitoring thyroid hormone treatment, free T4 is fine, but if you're just doing screening, you can save money by ordering a total T4 and it will give you the information you need. But the total of all these tests, at least at Children's Hospital, what is charged is over $2,000. So here's some final thoughts I have about interpreting abnormal labs. One reason there are so many abnormal test results is that often tests are ordered for patients with weight issues, mild short stature, normal growth rate, fatigue, behavior issues, and things that are really very unlikely to give not an abnormal result, but a significantly abnormal result. So remember that 5% of healthy kids will have values outside any lab test's normal range. So if one orders 20 or more tests, as is often the case, there's a really good chance that one of those tests, at least one test, will be abnormal. So my suggestion is to hold off, do your best to hold off on non-selective test ordering while monitoring the patient for whatever complaint that, brought them to your office. And I realize that some of, you may be confronted with parents who insist, we want lab tests, you're not doing anything. Please order labs to rule out such and such. And um, yeah, this is hard to counter except to say, I don't think that, the issue that you are bringing your child in for is going to be found with lab tests, but let's monitor it. If it may resolve on its own, if it gets worse, we can discuss either some targeted testing or referral. But anyway, as a MAVEN volunteer, one of the most common questions I get is, I saw this patient with X and ordered a long list of lab tests, which end up coming back normal. What other tests should I order? And what I would like you to consider is, before you order that long list of tests, if it's a straightforward problem, that you might get a straightforward answer. And this refers not just to endocrinology, but to many subspecialty. Consider asking us what tests might be useful for a specific scenario before you start ordering. And then if you do order and are confronted with an abnormal test, consider whether the result is really likely to be abnormal in a clinically significant way before referring the child to a specialist. Because test results which are just slightly outside the reference range rarely cause problems. And, how important is it to distinguish between subclinical disease states versus normal variants? On the other hand, test results that are well outside the normal range, idea TSH of greater than 20 or less than 0.1, or a random glucose of greater than 200 are a different story. Okay, I've really enjoyed talking with your group. I hope that you learned something new and that you might, be less inclined to order tests in certain situations. And, you can give them my email, Stephanie, if they have any further questions they want to address.
Yeah, thank you so much, everyone. I did put a few reminders in the chat. And again, just reminders about that CME that's going to pop up after you do close out of this webinar. But we appreciate everybody's time here. And we hope you all have a great rest of your day. Thank you, everyone.